So today's topic is endocrine pancreatic cancer. So classification of the pancreatic neuroendocrine neoplasm that has been a challenging based on the heterogeneous biology of this tumor. 8th edition AGCC cancer system distinguishes this tumor from the exocrine cancer staging criteria, but only considers size, lymph node status, MATs, which fail to address many nuisance of this tumor grade in presence of biological behavior of this cancer. So European Neuroendocrine Tumor Society (ENATS) proposed a classification scheme in 2006 that was later adopted by WHO in 2010 that grade this tumor based on the mitotic count and Ki-67 as follows. So grade 1 is well differentiated mitotic count index less than 2 per high power filled and Ki-67 less than equal to 2%. Grade 2 is well differentiated mitotic count index of 2 to 10 per high power filled, Ki-67 3 to 20%. Grade 3 is well differentiated to poorly differentiated mitotic count more than 20 high power filled, Ki-67 more than 20%. European Neuroendocrine Tumor Society. So all pancreatic neuroendocrine tumor are considered malignant, with grade 1 and 2 pancreatic neuroendocrine neoplasm generally grouped as well differentiated neuroendocrine tumor, and grade 3 they are grouped as high grade neuroendocrine carcinoma. Grade 3 are neuroendocrine carcinoma, high grade neuroendocrine carcinoma. However, this classification system is not perfect, as some grade 3 pancreatic neuroendocrine neoplasm are well differentiated and have less aggressive biological behavior and improved prognosis compared to poorly differentiated small or large cell neuroendocrine carcinoma. So there is one Zaidi and colleagues recently performed a multi-institutional analysis of 1,000 patients of pancreatic neuroendocrine tumors and described a novel scoring system for recurrence that includes symptoms, tumor size, Ki-67, nodal positivity. So low risk patients 0 to 2 points had a 2% recurrence at 24 months and compared to 14% intermediate 3 to 6 points and 33% high risk at 6 points. So none of the proposed staging system classification system appear to outperform the others consistently with regard to prognostic capabilities. So this is one important Zaidi et al. Scoring system includes symptoms, size, Ki-67 and node positivity. Low risk 0 to 2 points, 2% recurrence at 24 months and 14% intermediate point include 3 to 6 and 32% recurrence at 24 months with high risk in which points are more than 6. So pancreatic neuroendocrine tumor have incidence of roughly 0.2 to 1 lakh per, and yet autopsy shows that small subcentimeter pancreatic neuroendocrine neoplasm are very common, and they comprise roughly 5% of all resected pancreatic cancers, and pancreatic neuroendocrine neoplasm they are typically well demarcated and they are hypervascular. During IV contrast cross-sectional imaging then enhance focally in arterial phase. Microscopically, neoplastic cells are arranged in nested fashion with a high density of intratumoral microvessel, and the majority of well differentiated pancreatic neuroendocrine neoplasm have an indolent course and cured with the surgery alone. Even patients with the metastatic disease have a 5-year survival rate of 50%. So older studies reported that half of this pancreatic neuroendocrine neoplasm were non-functional, 50% they are non-functional, and half were functional due to presence of the measurable hormones in the serum. The balance has shifted dramatically towards the non-functional pancreatic neuroendocrine neoplasm being more common, and this is large part of the result of the rising of the incidence of small incidental asymptomatic pancreatic neuroendocrine neoplasm identified on cross-sectional imaging obtained for other reason, as utilization of CT scan MRI in the workup of abdominal gastrointestinal urological symptoms has increased over time. Insulinoma, that is the most common functional neuroendocrine tumor, 30 to 45%, and neuroglycopenic symptoms, they are associated with the excessive endogenous insulin production like Whipple's triad, documented hypoglycemia, symptoms of hypoglycemia, and resolution of the symptoms with correction of the hypoglycemia. So most common neuroendocrine is functional neuroendocrine is insulinoma, and there is Whipple triad, which include the documented hypoglycemia, symptoms of hypoglycemia, and resolution of the symptoms with correction of hypoglycemia. And gastrinoma, they account for 20%. So gastrinoma commonly comprise 20% of the functional neuroendocrine neoplasm, causes peptic ulcer and diarrhea by hypergastrinemia, and less common functional neuroendocrine is glucagonoma, associated with the glucose intolerance and rash of migratory necrolytic erythema, VIPoma, watery diarrhea, somatostatinoma, steatorrhea, diarrhea, diabetes mellitus, and gallstone. Familial syndrome with this development of pancreatic neuroendocrine neoplasm include multiple endocrine neoplasm N1, VHL, NF1, and tuberous sclerosis. And genetic landscape of pancreatic neuroendocrine neoplasm has been defined through whole genome exome sequencing. And compared to pancreatic ductal adenocarcinoma, there are fewer somatic mutations per tumor. KRAS mutation, there have not been observed. Commonly mutated gene MAN1, 44%, chromatin remodeling gene, mTOR pathway gene like P10, PIK3CA, tuberous sclerosis 2, and the latter gene group likely renders many neuroendocrine neoplasm marginally controllable with targeted therapy using mTOR inhibitors. Consensus guidelines have been published by the American Hepatobiliary Pancreaticobiliary Association. Resection is recommended for localized functional neuroendocrine tumor with the symptomatic pancreatic neuroendocrine neoplasm regardless of size, and non-functional pancreatic neoplasm with size more than 2 cm, medically appropriate patients. Observation is reasonable for size less than 1 cm non-functional pancreatic neuroendocrine neoplasm. Management of non-functional pancreatic neuroendocrine neoplasm 1 to 2 cm is controversial. Based on the recently reported national data, there remains heterogeneity in the management of localized non-functional pancreatic neuroendocrine neoplasm and stratified by size and facility type. Many patients with pancreatic neuroendocrine neoplasm in this size range can be safely observed with interval imaging, taking into consideration age, comorbidities, lesion growth over time. Multiple treatment options for patients with the advanced metastatic pancreatic neuroendocrine neoplasm: liver-directed therapy like resection, thermal ablation, arterial embolization, bland chemo, systemic somatostatin analog like lanreotides and dostatin, mTOR inhibitors, everolimus, cytotoxic chemotherapy, capecitabine, temozolomide. There is no current role of adjuvant systemic therapy following resection of localized pancreatic neuroendocrine neoplasm. Southwest Oncology Group is actively accruing patients to phase 2 randomized clinical trial comparing recurrence-free survival between patients who underwent surgery alone to surgery followed by capecitabine temozolomide for intermediate and high-risk ZID scored more than or equal to 3 well differentiated pancreatic neuroendocrine tumor. Thank you.